Hello everybody and welcome to this webinar with PhysiQuip Academy. I'm really excited with this webinar. We've had over 80 registrants for this session. It's a live session in which we're just going to have a few seconds to pause whilst we have people sign on to the live session. So if you are watching the recording, if you skip forward a minute or so, and then you'll be able to get the content there. For those of you who are joining, welcome to the session. We're going to get started in around about a minute or so. We have a nice variety of people on the session this evening, from lymphedema nurses, breast nurses, all the way through to oncologists, radiologists, and breast consultants this evening. So a really good mix. So hopefully a very good, session this evening. So as I said again, for the people that just joined on the live session, we'll get going in about 30 seconds or so, or we're just waiting for other people to sign in to the webinar. Okay. Hello and welcome everyone to this webinar on Ask the Author, Behind the Research of Preventing Cancer-Related Lymphedema by 69 to 81%. Thank you very much for taking your time out this evening and joining us. So you're aware, this webinar is going to be split into two segments. We're going to have a 15 to 20 minute presentation from Dr. Chirag Shah, and then we're going to follow this up with a question and answer session. Now, quick bit of housekeeping. The session is being recorded, so if you do miss anything, you can watch it back. We'll send you the link to the recording within 24 hours of the session finishing. If you do have any questions, there is a Q&A function which you can find at the bottom of your screen. Click on that, and then we'll get your questions answered during the session. For those who are watching the recording, if you do have any questions, then please feel free to email us at info@physiquip.com and we'll get them answered as well. So very quick introductions. My name is Dominic Smith. I'm the Clinical Applications Specialist at PhysiQuip. For those of you who aren't familiar with PhysiQuip, we are a UK-based medical distribution company. We work with several international companies, and our aim is to bring some of the best, most innovative technologies from around the world into the UK. As well as that, we also introduce some of the best speakers and clinicians from around the world in their different sectors to our education platform, like this evening with Dr. Shah. So with that, I would like to introduce Dr. Chirag Shah, who is joining us from Cleveland, Ohio in the United States of America. I'm going to shut up, Dr. Shah. I will hand over to you to take us through your presentation. Thank you.
Thank you. Good evening. I'm Chirag Shah. I'm a radiation oncologist. I specialize in breast cancer, and I practice at the Cleveland Clinic in Cleveland, Ohio in the United States. Before we get into kind of the discussion of the paper at hand, I think it's a good idea to kind of review the topic of breast cancer-related lymphedema. And when we think about breast cancer-related lymphedema, we think about the fact that the incidence of developing lymphedema is really based on how aggressive local regional therapies are. On the table on the left, you can see rates are as low as 0 to 3% with a lumpectomy alone, all the way up to probably 50% in cases where we have high rates of local therapy, including mastectomy, lymph node dissection, and regional radiation. Similarly, we've seen that radiation can impact the role of lymphedema based on the technique, whether that includes treating the lymph nodes or not, and whether it's given to the whole breast or to the partial breast. In terms of diagnostic modalities for breast cancer-related lymphedema, if we go all the way back to the original studies looking at really comparing, for example, axillary dissection to sentinel lymph node biopsy, a lot of those were done using circumference measurements. They're easy to perform, they're low cost, they're portable, and as I said, they were used in trials. The con is that they're relatively low sensitivity, and there's really an inability to detect subclinical lymphedema. And the reason we think that that's important is just like any disease process, if you can catch something earlier in the disease process, you're probably more likely to mitigate the long-term impacts of it. An additional challenge with the circumference measurements is there really is not a good consensus on standardized metrics as to when to initiate therapy. Water displacement is another technique, relatively easy to perform and has been used in studies in the past. still relatively low sensitivity and inability to detect subclinical disease with no consensus on standardized metrics. Really shouldn't be used in patients with infection or at high infection risks. Surveys are probably one of the easier things to do, often as simple as a clinical question saying, do you have any heaviness in your arm or hand, all the way to validated questionnaires. They're easy to perform, they're low cost, but they tend to be low sensitivity as well. Porometry is a relatively new technique, has increased sensitivity, but requires a larger footprint, higher costs, and there's a lack of long-term data. Bioimpedance spectroscopy, has been around for more than 10, 15 years now. It's highly sensitive, able to detect subclinical disease. There's standardized techniques and standardized cutoffs to initiate treatment, and it has a UK CE certification. We don't have long-term data, at this time, though we would hopefully expect that in the years to come from the PREVENT trial, which I'll mention shortly. And it can't be used on patients with implanted electrical devices or in pregnant patients. So focusing further on bioimpedance spectroscopy, this is just one of the newer devices. This is called a SOZO. It allows for the subclinical detection of breast cancer-related lymphedema. We have standardized testing protocols and published clinical practice guidelines in the Breast Journal on really how to make measurements, when to make measurements, and when to intervene. And as I said, there's standardized interventions with non-invasive interventions, including compression garments. With respect to early detection and intervention for breast cancer-related lymphedema, the idea is that if you can detect breast cancer-related lymphedema in a subclinical phase, you can allow for early intervention. So the key goal of early diagnosis is early treatment. And small prospective studies have shown the potential of such an approach. And with early intervention, we use things like a compression garment, not invasive, low cost, and relatively easy to use. Studies have shown that these types of programs allow for early detection intervention and is also cost effective in terms of looking at the costs of detecting early stage lymphedema. The PREVENT trial is a randomized trial. It's a multi-center throughout the world, including in Australia and the United States. And it's comparing bioimpedance to tape measurement with early intervention for both groups. And this study was published in an interim analysis, and I'm one of the investigators of this study. There was about 1,100 patients. I think that's important. When you look at some of the other studies I often get asked about, when you look at the numbers of patients, the number of events, it pales in comparison to this trial. The inclusion criteria were stage 1 to 3 breast cancers with at least one of the following: having undergone a mastectomy, an axillary dissection, more than 6 lymph nodes, regional nodal radiation or taxane-based chemotherapy. And they were followed, randomized, but to either bioimpedance or tape measurement. Initially, we used a trigger point with the bioimpedance of 10, but that was switched to 6.5 based on data that was published while the trial was underway. In terms of the tape measurement, for a volume increase of 5 to 10%, we randomized them. Anyone over 10% was referred to CDP right away, with the concern being that these patients already had more clinical lymphedema. In terms of the intervention, patients triggered and underwent 4 weeks of wearing a compression sleeve and gauntlet for 12 hours a day, with progression defined as a 10% or greater volume increase, and these were referred for CDP, and patients were followed for 3 years. And this is just a nice kind of comparison of the two arms. You can kind of see on the left side was the tape measurement, where volume was compared to baseline. Less than 5, they could follow all the way for 3 years. 5 to 10 is when they were basically given the intervention and followed. And then if they were over 10, they're immediately sent for CDP. In the LDEX arm, if they were less than 6.5 throughout, they were followed just like the less than 5%. If it was greater than 6.5, they also had a volume measurement. So there was a comparative arm of kind of both of these greater than 10% volumes automatically being sent for CDP. So there was consistency between the arms. Anyone less than 10% of the volume who triggered were given the intervention. And then if they stayed below 10%, they were followed for up to 3 years. And if they got over 10%, they were sent for CDP. And this was the interim analysis, basically actually more triggers in the tape measure arm than BIS. I think this kind of highlights the sensitivity of BIS actually to determine that someone's having lymphedema, and probably the intra and inter-observer variability associated with tape measure. And really the proof is in progression, right? The primary endpoint of the study was progression to complex decongestive physiotherapy. And there you already see a nearly 10% absolute reduction in progression to complex decongestive physiotherapy. When we look at the interim analysis, this is just a summary of what I previously mentioned, similar follow-up in both arms. These patients who progressed before intervention were excluded. They were similar in both arms in terms of the numbers. We've talked about the triggers. Interestingly, the median time to trigger was longer in the bioimpedance arm, then the tape measurement arm, and that the overall number of progressions, while not statistically significant, I think most would argue was clinically significant with a 10% absolute reduction. We then did an additional analysis looking at the impact of radiation on these patients. And interestingly, if you got no lymph node radiation, you saw less triggers of the bioimpedance, but you still saw high rates of triggers, even with tape measure for all the groups. So tape measure was not really discriminating based on risk, right? So, we know from no matter what source you look at, the more aggressive your therapy, the more you're likely for lymphedema, and your diagnostic should reflect that. Unfortunately, tape measure didn't really reflect that. All the groups showed basically 25% or more triggers across the board, whereas with bioimpedance, you're really seeing selective triggering, increased rates in patients who, for example, have an axillary dissection, people who are getting extensive lymph node radiation. So it's a nice way to show that BIS is able to discriminate based on the extent of axillary surgery and radiation. To the study at hand, we then did a lymphedema meta-analysis. And basically, the purpose was to evaluate the impact of monitoring techniques on the incidence of chronic lymphedema among patients monitored with bioimpedance and circumference as compared to background. This idea of a background rate was based on a previous meta-analysis in the Lancet Oncology in 2013 from DeCipio et al. Our study included 50 studies with more than 67,000 women included, and we compared rates of lymphedema between bioimpedance, circumference, and background. In terms of the results, the annualized rate of breast cancer-related lymphedema was around 4.9% with background, 7.7% with circumference versus 1.5% with BIS. And the cumulative lymphedema rate was about 13% with background, 17% circumference, and 3.1% with BIS. So overall, a 69% reduction as compared to background and 81% reduction versus circumference. And then to really look to make sure the full results of the study, and we started off by this basically shows that even with short follow-up, or long follow-up, there was really no difference. And by type of study, there was no difference. Similarly, when you look at patients who had a high rate of mastectomies, whether you saw patients having high rates of dissections, the findings were consistent. So we were able to do these types of subset analyses given the number of patients. So there were some subsets that had fewer patients, and therefore the conclusions are limited in those areas. And with that, I'm happy to answer any questions, and thank you again for the opportunity to speak today.
Amazing. Thank you very much, Dr. Shah. Very, well, if you come back one slide, is that all right, please? There we go. Yeah, a lot of data. So I think it's really interesting. I think it's great that obviously these research projects are being done. I mean, in terms of the PREVENT trial, how far along down the line is that? How far are you from publishing the end results?
Yeah, it's a great question. So, obviously we've completed accrual to the PREVENT trial, and we obviously expect the final results of the trial to be published, probably in the next year or so, ideally. Okay, perfect.
So for those people who are on the live session, we're going to open up the Q&A. So the Q&A function is at the bottom of the screen. Now this is your opportunity to just pose your questions about the lymphedema prevention pathway. The research that Dr. Chirag Shah has done and also been a part of. So please, this is a good opportunity to grill him on the data that he's, been able to pull together and really pick apart how that can potentially translate to your practice. I'm going to kick off with the first question that I get a lot when I am speaking to people about the pathway. And it's around the word prevention. Because up until about maybe 18 months, 2 years ago, we were talking about early detection. And that was the phrase that we used. And then obviously the PREVENT trial, the interim results suggested actually we can prevent this. Can you just clarify what we mean or what you mean when you're saying prevent?
Yeah, I think prevent is really about preventing long-term chronic lymphedema. I think that obviously the goal would be to eliminate it altogether, but I think right now that's probably not where we're at. So I would say prevent is really driven by using a philosophy of basically prospective lymphedema surveillance and early intervention to prevent and really limit the risk of chronic life-altering lymphedema. So
that's it. So basically, you're detecting subclinical stage 0 lymphedema with BIS. And the prevention aspect is that with the right early intervention, the right time, that could be compression, exercise interventions, could be decongestant therapy if required. That the idea is that you get on it early, it's not going to develop in, or I'll say not, you're going to prevent the probability of it developing into a stage 1, stage 2 edema, which means obviously it's easy to manage.
That's exactly right. Yeah. So the bioimpedance itself is not preventing anything. Bioimpedance is giving us the information to allow for early intervention, which is preventing something.
Okay, so that's another thing I'm going to clarify. When you talk about bioimpedance, is it diagnosing or is it a screening tool? Because that's the other one that we get.
It's a good question. I view it as more of a screening in the sense that, I almost view it like a vital sign. And so in the same way we check people's blood pressure, to screen for hypertension, and then subsequently diagnose it, I think of bioimpedance to be very similar in the setting of a breast cancer population.
Brilliant. And I think from the UK's perspective, I know Australia have got 100 systems now, and more in there. I know in the States, it's been quite used a lot. And it's quite a new concept here in terms of using bioimpedance. There's a few pockets that are using bioimpedance for the lymphedema pathway. But one of the things, there's a little bit of, what's the word I'm looking for? Nervousness, cautiousness about using the word prevent, and particularly approaching that with patients. So in your practice, how are you broaching that with patients? How are you introducing this pathway? Are you calling it a prevent pathway? What's your process from that perspective?
Yeah, our pathways are probably a little bit different in the sense that in our current clinic, the way we do things is I see patients in conjunction with my colleagues in other disciplines. So in our breast cancer clinic, there's medical oncologists, breast surgeons, genetics team members, everyone kind of sees patients together. And our SOZO unit is actually right next to the scale where people take their weight. So for us, it's part of our basically pathway where for patients who are going to be at risk of developing lymphedema, they have the SOZO measured at the time of their other vital signs being captured when they walk into our clinic. And the understanding with them is really the discussion that this is kind of just a part of their check-in process each time and a part of their breast cancer follow-up and vital signs, and that based on their measurements, we will intervene based on those. That's kind of how we've designed our clinic around the SOZO.
Okay. And I think coming back to sort of the research side of things, so I know we're kind of touching on clinical practice, there's obviously that bridge between research and what can be done in a controlled environment, and then how does that actually translate to practice? And that's the thing, is that we're seeing this data and we're going, oh, that's amazing on the face of it. How is that realistically applied? So, do you think the data that you've collected from the meta-analysis and the PREVENT trial, is that realistic for one, and how does it translate into practice?
Yeah, it's a great question. I think, with the SOZO device being a change from the previous devices, and that a patient basically just stands on the device, almost like a second scale, it takes less than a minute or two to capture a measurement. So in terms of efficiency, it doesn't slow a clinic down. And we've even looked at that and published on that in the past, showing that it's not going to really increase the amount of time your visits take. It can be done right away, kind of as people come in. So it's very easy and practical to use. And then in terms of intervention, once your team is kind of on board, it's very easy to say, listen, we're going to use this 6.5 guideline, and then subsequently intervene and kind of have processes in place for referrals for those types of compression garments and things like that.
And I think again, from the data perspective, you claim that, you've reported and published that this, particularly for early intervention, significantly reduces the relative risk of breast cancer-related lymphedema with 69% compared to background monitoring. Just clarify background monitoring.
Yeah, so background monitoring was kind of a catch-all. Like I said, we used that from the previous meta-analysis for consistency. So, for example, someone who had porometry would fall into background, and that may explain why, for example, the reduction is a little bit less as compared to background as it is compared to circumference, because just that was how the things were defined in the previous meta-analysis, and for consistency, we kept that to be the same.
Yeah. So you've seen 69% reduction relative with background monitoring, and then 81%, which is a considerably high number,
Yeah.
To circumference. Now, obviously, circumference is standard, standard care. We do the circumferential measurements consistently in lymphedema. But how does those? So that's obviously based on 50 studies across 67,000 women. So it's a big population. In terms of what Cleveland Clinic are doing, are you seeing a similar trend? Like for the women that are going through and having the cancer treatments, having the surgeries, and going through the follow-ups, have you seen a definitive drop-off between before you implemented this pathway and then after you implemented this pathway?
Yeah, I mean, it's a great question. So one, I haven't used tape measurement in probably more than 10 years. So I can't tell you I can't tell you about any experience with that in my practice now, just because I haven't done that. But also our program is quite specialized. So for example, even in high risk patients, we sometimes do what's called a lymphovenous bypass and then use LDEX to follow them. So overall, I've seen a drastic reduction in really that chronic life altering lymphedema, based on doing things like, early monitoring with bioimpedance, but also my surgical colleagues doing procedures like lymphovenous bypass and things like that. So it's, I think, a multifactorial as to why I'm not seeing probably what I saw 5-10 years ago in terms of the rates of that chronic lymphedema.
Yeah. We have got another webinar with, I think Ali's on the session this evening, who's a service in the UK. We did actually talk about their incidence rates as well. So people who are watching this back on the recording, we do have another webinar where we did talk about those kind of incidence rates. Now I want to kind of just touch on like those 50 studies that you included in the meta-analysis. Mm-hmm. Are they all RCTs? Some of them, are they case studies? Like what's the mix of?
Yeah, so actually I can go backwards and show the mix real quickly. Just a second here. It's not letting, there we go. So if you look down here, the number of studies that were prospective, randomized, and retrospective, that's the bottom set of rows, you can see that it was a mix. So there were, for example, 6 randomized trials in the no intervention. There was 1 in the BIS, 3 in the circumference. Then when it comes to prospective, 19, 4, and 6, and then retrospective, 10, 2, and 2. So I think this is kind of more reflective of real world practice than anything else. And that's why those studies were all included, because they met the inclusion criteria of the meta-analysis.
I mean, do you think it's skewed the meta-analysis at all, or do you think it's just because they all had similar designs?
Yeah, so we tried to balance that out. And I think one of the other things you see is that even when you look by type of study, the benefits still held, regardless of whether you held people to the RCT standard, whether it was to the prospective standard or the retrospective. Really, we saw consistent findings. So, I mean, that was part of the reason we ran this analysis to see is, are we being skewed by the type of studies in each group? And it just didn't seem to be the case.
So I'm going to just pause a second. For those people who are on, I know I've got quite a few questions that have been pre-submitted that I'm kind of getting through. I know some of the questions are actually, my personal interest as well after reading the paper. If you do have any questions, please pop them in the Q&A. There's been a few more people that have joined the session. So if you've got any questions about the work that Dr. Chirag Shah has done, Q&A functions at the bottom of the screen, pop it in there and we'll get them answered for you. I'm just sort of touching on the study side of things as well. So obviously, improving or reducing incidence rate from 69, 81%. Have you come across any papers or any studies that were opposite to that, or you saw that weren't, those kind of results? Because obviously, just to sort of fill that out, because people may assume, even in the inclusion criteria, that you can omit for the papers that the study design wasn't quite right, or whichever, and it might not have a true reflection on all the research out there. So have you come across anything that?
Yeah, I mean, I think there are studies out there that have found kind of contrary results, and I think that when you look at those studies, they may not be randomized. They may be using definitions of lymphedema detection that are not subclinical, right? So if you're going to compare, for example, using RAVI, for example, or relative arm volume, and you're using a constraint of 10%, then you saw from even the PREVENT trial, we're not using 10%. We're staying below 10%. The idea being that subclinical is going to be seen below 10%. So, things like that, or, you see the studies and they comment on things like that, but then you see that, 15, 20% of the patients are progressing to chronic lymphedema. You can see in the PREVENT trial, we're seeing about 4%. So I think when you look at those studies, it's all about kind of putting them in context and looking at those studies and really taking a deep dive into how they're defining lymphedema and what their rates of chronic lymphedema are compared to, for example, interim analysis of PREVENT.
Yeah, and it comes back to that thing of, sort of a trip down memory lane back to university, is that critically analyze and, not necessarily always take things at face value, look at the study designs, find the limitations, find the, the variations, whatever it might be, look at the reliabilities of the study designs, really. In terms of the pathway and translating it into practice, like for the PREVENT trial, particularly, I know that's worked on a particular model. Obviously, the meta-analysis 50 studies, they've all got slightly different models in terms of the follow-up, whether they're prospective, retrospective, whichever. What is the pathway design on the PREVENT trial, i.e., you've got pre-treatment baseline, and then what is it thereafter?
Yeah, it's a great question. So for the trial itself, yeah, we had a pre-treatment baseline, and then subsequently every 3 months, and then we stretched that out to every 6 months, and there were a couple optional visits as well. For example, and I think that's really a nice way to go for like the first 2 years, to do it every 3 months, and then based on risk and how their patients are doing, you're potentially stretching the visit length out from there to every 3 to 6 months, or even annually if it's someone you feel is relatively low risk. So that's how we do things. I think the other question that commonly comes up is what happens if the patient doesn't have a preoperative measurement. You can still use bioimpedance even if they don't have a pre-treatment measurement. It wasn't, the trial didn't do that, but there is data supporting that. So that's also something that I sometimes get asked if that didn't happen.
Yeah. Now, I know this is something that we are talking about a lot, bioimpedance spectroscopy, of course, physically represent technology. So it's something that we're talking about now. It might be considered a bit of a loaded question, but I just want to clarify. Are there one, other technologies available? And two, do you have to use bioimpedance? And what, so kind of what's the difference with bioimpedance? Can you just use circumferential measurements and that side of things?
Yeah, I mean, it's a great question. So I think, yes, there are other methodologies beyond bioimpedance. As I mentioned in my opening slide, tape measurements been used for years. Water volume displacement, pyrometry, these are all things that are used pretty commonly. And, if, for example, bioimpedance isn't available, I think it's certainly reasonable to consider circumference measurements. There is older data, I think, using some of those technologies, saying that, even early detection with those may improve outcomes. So I think that's certainly something that if you don't have bioimpedance at your clinic, and I don't think that means you shouldn't have a prospective lymphedema surveillance program. Obviously they still want to make sure you watch for patients developing it and trying to intervene as soon as possible.
Yeah. And with the interventions, obviously, again, coming to translation of practice, we're moving this, so you've got the rates, you've got the regular follow-ups. Now, we know that not every patient will develop lymphedema. I've got the paper in front of me that you reference, Discipio, I think it is.
Yeah, Discipio, yeah.
They found the incidence rate of breast cancer-related lymphedema was approximately 1 in 5. So, you could be potentially screening 100 patients, and only 20 are going to pick up. Now, one of the issues, or the challenges, sorry, I say, we face in the UK, particularly in NHS, is just the capacity is quite often, having to measure 100 patients regularly, follow-ups a couple of years afterwards, just might not be feasible. So do you categorize patients into high risk, low risk? Have you seen people do that? Is it something that you do yourself?
Yeah, I mean, I think you can certainly classify people, lymphedema risk for sure based on their clinical pathologic and their treatment related effects. And so I think that, you start kind of adding factors, right? Did they have a mastectomy? Did they have an axillary lymph node dissection? Did they get lymph node radiation? And you're going to see a skew based on that. So you may have some very low risk patients who have lumpectomy or lumpectomy plus partial breast radiation, and their risk of lymphedema is very low, and they may not need that type of surveillance based on their incidence rates. And then you take the patients on the other end who have the highest rate, who probably have had mastectomy, axillary lymph node dissection, lymph node radiation, and they may be at the highest. And then you can basically take the highest risk patients and slowly work your way down the risk to see what a program can actually appropriately cover with their technologies, right? Given the limitations of, like you said, of the number of people, and kind of work your way backwards in terms of risk and what's possible.
Perfect. And I think, it's, again, coming from the NHS perspective, UK, it's a very different model to the States. And I think it's a very, it's like the elephant in the room, really, with this discussion, is, your system is very different to ours. Albeit you deal with the same clinical problems and you have very, very similar, if not the same interventions. But, finance is a massive factor. The States is more, the States healthcare system is more flush with cash. Would you agree? Probably, it's cash more readily available. I guess you still have to go through the same rigmarole of business case. You've got to find that. So I guess you have still the same challenges that, yes, there might be more money available, but you still have to seriously justify it and prove it.
I mean, I think, even in the States, I think we still have to justify kind of bringing in new technologies and new equipment. And, obviously the NHS is a little bit different than the American system, but I think one of the things that American organizations are doing, which is similar to what the NHS has done, which is really looking what costs to deliver care. And I think that's something that, all organizations, regardless of where they're delivering care, are starting to do more and more of. So I think part of looking at the role of bioimpedance is looking at the costing of it. What does it cost you to run such a program? And then are you preventing downstream costs, right? So this is where I think an ounce of prevention is worth a pound of cure, in that sense. And I think that's something that, regardless of whether you're in the States or whether you're in the UK, I would imagine even the NHS would get behind something like that, where it's, by putting a little bit in up front to do these surveillances, you're preventing things like chronic lymphedema, developing infections that require admission, these more high cost things downstream.
Yeah. So I suppose the financial models, is it fair to say that the insurance companies in the States are similar to the NHS in terms of they don't really want to pay out? They want to find the cheapest, the most cost-effective solutions that means that they don't have to pay out on expensive treatment. So if they can prevent things like lymphedema, reduce the rates of clinical lymphedema, that's something they're going to invest their money in to reduce the costs down the future. I don't know whether that's going to be, a lot of people listen to this thinking, no, that's not comparable. But from your perspective, from your opinion and side of things, do you think it's comparable?
Yeah, it's a good question. I don't have a huge amount of experience on the insurance side in the United States, but I think overall insurance companies are trying to say, how can we provide our patients the best care with the highest value possible? And I guess that would translate to the NHS, right? Is how do we provide the best care possible to people while providing the best value for the resources that are being utilized to deliver care?
Yeah, and do you have, again, I know it's a different model, because the NHS is, very much about saving costs, maximising budgets that they've got, minimising, essentially you want patients going home, self-care, all that kind of thing, self-managing, keeping them out of hospitals, preventing cellulitis, those kinds of things, which we know that as soon as they put, stage 1, stage 2s, they're more susceptible to cellulitis. Do you know of anything that's where there's been a cost analysis of services, pre-prevention pathways, post-prevention pathways that may showcase actually in the long term you saved money on because you prevented more clinical lymphedemas?
Yeah, so we did a cost analysis based on the interim study of results from PREVENT, and that was published in the Breast Journal, I think a year or two ago. And basically it compared surveillance with bioimpedance versus surveillance with circumference, and it accounted for things like hospitalizations as well as the cost of actually doing the measurements as well. So the cost of the staff, the equipment, everything was incorporated into this. And we looked at those two techniques, and it actually showed at 1 in 3 years that there was a cost savings associated with using bioimpedance. And we also looked at the number of patients coming into the clinic, because obviously these costs will depend on how many patients you're bringing through your clinic in a yearly, monthly basis. So we actually accounted for that as well, and showed that even for small practices all the way to big practices, you're still seeing consistent benefits.
I think that's going to be a big part of it. I think also one of the big questions is who delivers these measurements, who ultimately is going to run this pathway, because we've had it here. We've got consultants on this session who, in a similar position to you, may be going, this sounds pretty good, but I don't know who's going to do this, who's going to deliver it. Vice versa, there's going to be nurses on this call who are going to go, yeah, somebody's going to come to me and say, I'm going to add more to your plate, basically. So again, two part. One, how did you sort of deliver that? You know, who does it? Sorry. One, who delivers it? And two, like, how did you broach that, and what was the feedback from them of essentially adding more work to their plate?
Yeah, no, it's a great question. So in our practice, it's done by the medical assistants that room the patients. So they underwent the training, and then they have the patient get on the device and get the measurement, and then the measurements are brought to us. And then we make the decision on kind of intervening and all that. So the added time is for the medical assistants, to make the measurement, but then typically speaking, in my practice, it's the surgeons, the medical oncologists, the radiation oncologists who are involved. I know at other practices, it's being run by the physical therapy groups. It's very institutionally dependent. So it can be anyone from people working in a breast clinic all the way to kind of physical therapy clinics to some kind of combination or hybrid approach. There's lots of different options available depending on a practice's workflow.
Yeah. I think generally here in the UK, it's probably going to be more breast nurses or healthcare assistants probably delivering the measurements. And then again, like you say, it depends on the institution, it depends on the pathway and the clinics involved. I think most may probably end up falling under the lymphedema clinics, nurses and physiotherapists that work in those departments. I suppose, with this pathway, is it a fixed pathway, like you have to do it this way, or can it just be tweaked to what's actually best for the?
Yeah, I think it's flexible and variable, and it also should be patient-centered, right? So, most of my patients, they like getting the measurements, and if they do, that's great. Some of them they don't, and so that's okay. I think at the end of the day, it's all about what's best for the patient in their world, right? So that not every, we really center on what's driving the patient and kind of their interest and their motivation, making sure they're engaged with it. The other part about it is understanding kind of from the beginning, kind of what the process is, and kind of explaining, if we see these numbers change, this is where we're headed. Is that something that you're supportive of? And making sure you're getting buy-in from the beginning and then constantly following up with them. But of course, we want to make sure these things are individualized to the best interest of our patients.
That's an important thing, actually, to individualize, isn't it? It's like, is it difficult to individualize it? Because as soon as you mention individualize, you're thinking of crime. That's personalizing something, that's putting something very specific for that person. That's cost and time. Mm-hmm. Is it easy to just individualize because you've got a measurement specifically for them, very quick, or is it, does it add more pressures on to people's working days?
No, I think it's actually kind of a stress reliever. I think a lot of patients are worried about lymphedema, and a lot of patients want to know what they can do. And I think getting that number provides them reassurance, right? And it lets them know that it's actually being watched over. It's not something that we're just waiting for you to develop really chronic lymphedema and then we'll do something. It makes them feel that their treatment team and their healthcare team is watching over them for the risk of chronic side effects, just like we are for other potential chronic side effects of cancer therapies.
Yeah, that's cool. So I've got literally a few more questions that were submitted. Again, for the people who are on the session, please put some questions in. I'm presuming there's not been many questions coming in, so hopefully we're doing a good job at asking all the questions that people want to hear, and all the pre-submitted ones, again, are the ones that people want to hear. If we have missed something or there's a really burning question, please don't be shy. I won't mention my name. I'll just ask the question. Quite often the simple questions are the ones that we miss, and the ones that are burning questions. People are on the call now, you are day-to-day with this kind of thing. So please pop forward any comments, any questions, and we can get Dr. Shah's response to that. I just want to talk about standard of practice. This is something that's come in about, like, what is the standard of practice in the States? Is lymphedema prevention the standard now, or is it something that's still being introduced?
I think it's evolving. I think you're seeing more and more folks really believe in doing prospective. So you're starting to see it kind of disseminate. Another big thing is, in the States, there's a big focus on survivorship, kind of, which is the transition from, the active treatment of cancer, or in my case, breast cancer for my patients, to kind of not only monitoring them for recurrence, but monitoring them for side effects of therapy. And so as part of a growing movement to kind of expand survivorship programs, you're seeing a lot more proactive lymphedema surveillance throughout the United States.
And do you think that's where things are going? It's just, I mean, say for the States, Australia, I know, are doing it as well. And are you just seeing that this prospective surveillance prevention for lymphedema following cancer, is that just now becoming standard of practice in States, Australia, and some other territories in the world?
Yeah, I think it's absolutely expanding. I think, obviously, I think a lot of centers would say it's absolutely the standard. I think other centers would say we're still waiting for more data, but I think you're definitely seeing a move in the direction of kind of considering it a standard practice.
Yeah. And I just want to point out as well, because we've talked obviously breast cancer, that's your background. I know there's a lot of data behind breast cancer. This is applicable to gynae and legs as well, so melanoma and that kind of thing. Have you seen many papers in that sector at all?
I know there are some papers absolutely looking at lower extremity lymphedema following excision of different gynecologic cancers, for example, vulvar cancer and things like that. I believe there are actually multiple prospective studies in that space, a little bit outside of my area, but absolutely. And same thing, melanoma, if they're going to have an axillary lymph node dissection, same type of risk factors. If they're going to have lymph node dissection and axillary radiation, that in itself could be risk factors and something that could be followed with LDEX.
Yeah, and then so this is all applicable, so arms and legs, it's all applicable. I know breast is one that comes up a lot. I know the system doesn't measure breast, but do you see, because you're having that prospective care, you're seeing them relatively regularly, you're still doing those checks. So you're going to do the physical checks. The patient, my brush was being a bit tight, or actually I felt a bit tight. So it's not measuring it, but because you're seeing them regularly, you're picking up breast edemas earlier as well. Are you seeing that?
Yeah, I mean, I think just having regular follow-up with patients certainly leads to physical exams, and obviously physical exams can find things like breast edema, tightness, discomfort, seromas that are persistent as well. So absolutely, I think they all go hand in hand. Kind of part of that survivorship care is being more attentive to those types of things that can have major quality of life implications for patients.
Yeah, I just had a comment come throh, which I really do appreciate. So just to, I think it's really good for me to hear this as well. I think a lot of people who are listening back is one of the problems and challenges with the NHS breast services in the UK is that many cancer centres now have patients in what they call open access supported self-management with no routine follow-up appointments after active treatment, except for an annual mammography. This means that patients are not returning to clinics at the end of active treatment. So prospective bioimpedance screening may therefore become more feasible in private care as patients have routine follow-up appointments. So the model of insurance funding for this intervention, also in this model of insurance funding for this intervention becomes an issue. I know that is an issue. They've cut things, and I suppose, I don't know, they might be able to comment a bit further. The lady that just commented, there has been the pullback away from regular follow-ups. Obviously, I know COVID's probably had, I know it's happened before COVID anyway, so less people coming in and more people coming out. I don't know, is there anything that's happening like that in the States?
No, honestly, I would say, follow-ups are pretty standard for us, and we typically follow. In the States, we have something called the NCCN, or the National Comprehensive Cancer Network, and they provide a set of guidelines not only regarding treatments that are standard of care based on stage, but also for follow-up. So they have a relatively standardized follow-up schedule. And so we do try to be efficient so that the patient's not seeing multiple doctors at different time points, but we want to make sure they're seeing one of their physicians regularly for the first 2 to 5 years for sure. So many of our patients will be seen every 3 months by one of their specialists for the first 1.5 years, 2 years, and then it'll go to probably every 6 months, and then yearly is very common in the States. So yeah, it's a little bit, I would say that's probably a little bit different than the NHS model that you just described.
Yeah, I mean, it's going to be a challenge, and I mean, I'm not frontline working, so, and I'm not not privy to the information, the decisions that are made in that area. But I know there are NHS services that are using this, that they've reduced their clinical lymphedema rates in arms considerably. I mean, I suppose we said people are waiting for more data. I mean, 50 studies, 67,000 women. That's it's a pretty big study. There's pretty strong data there. I know that this pathway is recommended by the American Association or the American Society of Breast Surgeons. I know prospective model of care is in the consensus guidelines of the International Lymphedema framework. I know it's recommended by Australasian Lymphedema Association as well as the National Lymphedema Network. There's a lot of international groups and national groups that recommend this. And I suppose, I'm actually going to try and step away from it. It's difficult because I've got physical behind me. I'm going to try and step away from it as a clinician. Like, I've seen the data, I've seen the results. We're preventing, we are reducing the rate of lymphedema with prospective care. What would patients say? I think, if we can prevent them from getting a clinical 2-3 lymphedema. I know we're going to be faced with the facts that a lot of these decisions are out of many of these therapists' hands, and I know therapists and nurses will want to be doing this. When you're approaching people, what do you think? Is there more data available? What's the best approach for people? Is it just, building a business case, take it to managers and saying, look, we could potentially be saving a lot of money by reducing this? If you've got any advice, Chirag, about, how can we potentially, say, overcome these problems?
Yeah, it's a tough question, and I don't have much experience with the NHS and how they make decisions. But for me, the way I've always done things is I try to think about what's best for my patients, and then I try to advocate based on that. So first and foremost, by advocating, by saying that I'm going to be able to help the people that I'm responsible for taking care of. So I think that's the first thing, is showing why this is helpful for patients and how it impacts their lives. I think the next step is saying, how can we do this in the most efficient way possible, so that we're not, using more resources than are needed, but are using appropriate resources to provide that benefit. And then obviously the last part is, the economics of it, which, obviously the NHS looks at things differently than, the United States would, but trying to understand kind of what their drivers of tolerability are, and then trying to create models based on published data that address those questions that they're looking for. And that's typically how I would think about it.
Yeah. And I'm sure that, there's going to be people listening to this that, that will share the frustration that a lot of these processes are just out of your hands, and it's very difficult to get funding. I know there's quite a few clinics, lymphedema clinics, have been affected massively by the pandemic, and other services have been affected massively. So I know it's not a, timing is everything. Having the right person, the right contact is everything. So, I suppose the message is like, look, the data is there, the data is getting there, there's networks available. You're the Cleveland Clinic. For people who aren't familiar with the Cleveland Clinic, what's the scale of the service like? Where do you,
Yeah, it's a great question. So the Cleveland Clinic, I guess for current rankings, is the number 2 hospital in the United States. Mayo Clinic is number 1. Cleveland Clinic is number 2. At my main office, which is the main campus of the Cleveland Clinic, I think our main hospital has, well over 1,000 beds at the main hospital. We have a dedicated cancer center, which is 6 stories. It's a large institution. And then it has what we call satellite hospitals and satellite practices, not only in Ohio, but in Florida and other states. We have some programs in Canada and also in Abu Dhabi as well for cancer care as well. So it's an international organization. And the Cleveland Clinic is opening a hospital in the United Kingdom, the Cleveland Clinic, United Kingdom, London, as well. So it's an international organization.
Amazing. And then, in terms of other sites that are using this in the States that you know of, are the Mayo Clinic using it? Is that the number 1? Have they got this in place?
Yeah, so Mayo Clinic, I know the Mayo Clinic in Florida is, because they were part of the PREVENT trial. So yeah, in terms of other hospitals that are using it in the United States, just as part of the PREVENT trial, Mayo Clinic was involved. Vanderbilt was the primary or the home institution of the trial. MD Anderson was involved as well. So, MD Anderson, obviously a well-known cancer center, one of the leading cancer centers in the United States as well.
Amazing. No, I think that's, it's all been really good. And I think it's something that we want to make more noise about. Again, it's easy for me to say because I'm not on the front line of this. But I know, quite fortunate to have, be able to have conversations with yourself, Chirag, and also speak to a lot of the clinics in Australia. And there's a little bit of envy. These these pathways are going well. I've spoken to quite a few patients from those areas as well, who, it's amazing. their stories. I know there's challenges in the UK. In terms of the PREVENT trial, you've mentioned, so that's going to be in hopefully next year or two, that final.
Yeah, we don't know for certain, but yeah, hopefully in the next few years. Yeah.
Fingers crossed that comes through. But you've got interim results published, yes?
Yes.
So for those, for anybody, the follow-up email that we send out, for anybody watching the recording, I presume we can get that interim data and send that out to people.
I'm sorry, what?
Are we able to send that data out to people?
Yep. It was the interim analysis was published in the Annals of Surgical Oncology about 2 years ago, about a year and a half, 2 years ago. So that was actually a published manuscript and also presented at I actually believe the American Society of Breast Surgeons annual meeting as well. So it was both presented and published already. Right.
Okay. And I guess we've got free access PDFs that we're able to share.
Yep. Yeah, absolutely.
So yeah, anybody on the recording, anybody on this one, we can share the interim results of that if you haven't seen it already. We'll just send that out with the follow-up email. I think, there's no more questions that have come in. What I want to have is the opportunity to, for the people that are watching this, listening back to this. At PhysiQuip, we've seen, obviously we work with Bioimedance, we work with this pathway. Obviously, we're very fortunate to speak to people like yourself, Chirag, and learn about the research that we're doing. We are looking for flagship sites in the UK. There are a few sites already delivering this and getting extremely good results. If people are interested in doing this, we keep really keen to support. Obviously, we know there's challenges, there's barriers, there's red tape available. We want to try and support you as best we can. The evidence is there. If you do have any questions critiquing any of it, please do. We'll get them answered. We'll get comments on it because we want to make sure that it's supported in as many ways as possible. But as I mentioned, we're looking for flagship sites. So if people are interested, if they want to find out more information about that, we really want to try and get more sites into the UK using this and introducing this to practice. So we'll send this out obviously at the end. Anybody listening, please feel free to reach out. Dr. Shah, have you got any other comments at all that you'd like to cover?
No, I appreciate the invitation to speak today, and obviously we'll get the draft of the interim analysis that's available publicly available to everybody.
Okay, amazing. So with that all said, could you just click over to the next slide for me, please? Sure.
Yep.
So, like I said, thank you everybody for joining us this evening on the live session. Really do appreciate you taking the time out of your day. I hope you've all learned something and find it quite interesting. As I've mentioned, any questions, please get in touch. Dr. Chirag Shah, thank you very much for your time, your expertise, sharing your data and your experience with this and putting up with me grilling you for a little bit. Do appreciate it. So for everybody on the session, you'll receive a follow-up email with a survey link. If you could just take a minute or so just to fill that in. We'd really appreciate your feedback. And if you'd like to do any follow-up sessions, please let us know and we'll look to facilitate that where we can. We'll also send you the link to the recording. So if you do want to send anything back, you want to share it with any colleagues in oncology, or whichever, anybody within your networks that you feel may be interested, then you can share that around. And any feedback is more than welcome. In terms of upcoming webinar, as you can see on the screen, we do have one this Thursday with Professor James Moore Jr. We did one with him last year on the effects of positive and negative pressure on lymphatic pumping. We're doing a follow-up session with him looking at the roles of lymphatic fluid flow and the immune system function. Really interesting topic. So hopefully you can make it on to that session. Again, people watching the recording, any questions, if you want to reach out, our email is info@physiquip.com, which you can see on the bottom right of the screen. Otherwise, thank you very, very much. We all hope you have a good evening and a good week. Dr. Shah, thank you very much for your time. I know it's early afternoon there, so enjoy the rest of your day.
Thank you very much.
Thanks all. Take care.